Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 572 of our pharmacotherapy series, which majors in geriatric drug use. The first case reads, AMG is a 75-year-old female, with a height of 5 feet 4 inches, who weighs 120 pounds, with a serum creatinine concentration of 1.9 milligrams per deciliter. She has an acute exacerbation of heart failure, abbreviated as HF. She is given furosemide 40 milligrams orally, but this produces little increase in urine output or resolution of her symptoms. My first question to you reads, what would explain AMG's lack of response to furosemide, and how might the desired response to furosemide be achieved? The correct response is, the extent of furosemide absorption is not changed in older patients, but the rate of absorption is slowed. This results in a diminished efficacy of the drug because active secretion into the urine, that is the rate of entry, must reach the steep portion of the sigmoid dose-response curve for maximal effect of the drug. AMG should be given a 40 mg dose of furosemide intravenously to bypass the problem of decreased rate of absorption. High sodium intake or concurrent use of non-steroidal anti-inflammatory drugs may also decrease the effectiveness of furosemide. Further increases in dose of furosemide may be necessary, with consideration of a continuous infusion in patients with severe chronic renal insufficiency. Distribution. There are a number of age-related changes that may affect the distribution of drugs in the body. Total body water and lean body mass both decline with age by 10% to 15%, and total fat content increases by 20% to 40%. Thus, the volume of distribution of drugs that are distributed primarily in body water or lean body mass, e.g., lithium or digoxin, is decreased in older adults, and unadjusted dosing may result in higher blood levels. Conversely, the volume of distribution of highly lipid-soluble drugs, such as long-acting benzodiazepines, e.g., diazepam, may be increased, thereby delaying maximal effects or leading to accumulation with continued use. Serum albumin concentrations were found to progressively decrease for each decade beyond 40 years of age, reaching a mean of 3.58 grams per deciliter in those older than 80 years of age, and this may reduce protein binding. Changes in protein binding due to aging alone are thought to be only clinically significant with highly extracted drugs, drugs that are highly protein-bound, that have a narrow therapeutic index, those with a small volume of distribution, and those given intravenously. Other factors in older patients that may also affect binding include protein concentration, disease states, co-administration of other drugs, and nutritional status. AMG is brought to the emergency department, abbreviated as ED, for evaluation of a shaking spell. In the emergency department, another spell is observed, starting with shaking of the left arm and progressing into a generalized tonic-clonic seizure. A loading dose of phenytoin 1000 mg is given intravenously over 30 minutes. AMG is admitted to the neurology unit for further evaluation and given phenytoin 300 mg by mouth at bedtime. Is the phenytoin regimen appropriate for AMG? The next question reads: what laboratory tests should be ordered, and how often should these be monitored? The correct response is: AMG received a phenytoin loading dose of 17 mg per kilogram, that is an adult dose 15 to 20 mg per kilogram, and is receiving the usual oral daily maintenance dose. Monitoring parameters include a serum sodium concentration to rule out a hyponatremia-induced seizure. Because phenytoin is 90% protein-bound, a serum albumin concentration should be drawn. In patients with hypoalbuminemia or renal impairment, free, that is unbound, phenytoin levels should be monitored. A serum phenytoin concentration at discharge to determine whether the desired therapeutic serum concentration has been achieved is also recommended. A follow-up, steady-state serum phenytoin concentration should be obtained in 10 to 14 days to evaluate the current dose and to determine whether dose adjustments are needed. The serum phenytoin concentration should be monitored periodically thereafter and whenever an adverse drug reaction or seizure occurs. AMG returns for a follow-up appointment 2 weeks later after having labs drawn. Serum albumin concentration is 2.2 grams per deciliter, sodium 140 milliequivalents per liter, and serum phenytoin 15 micrograms per milliliter. AMG complains of drowsiness and has a wide-based, unsteady gait. My next question to you reads: what is the most likely cause of her symptoms? The correct response is: although the serum phenytoin is within the therapeutic range, that is 10 to 20 micrograms per milliliter, phenytoin is highly protein-bound, and in the presence of low albumin, free phenytoin concentrations could be higher. A corrected phenytoin level can be calculated using an equation. Total phenytoin concentration is equal to total phenytoin measured divided by opening brackets 0.2 multiplied by serum albumin in grams per deciliter plus 0.1 closed brackets. This would produce an equivalent phenytoin concentration of 27 micrograms per milliliter, explaining AMG's symptoms, assuming her serum phenytoin concentration is at steady state. In AMG's case, free phenytoin, unbound phenytoin, concentration monitoring would be appropriate, if available, and her dosage should be adjusted accordingly. Regarding metabolism, AMG's phenytoin metabolism may be affected by factors known to influence hepatic drug metabolism, which include disease states, concurrent drug use, nutritional status, environmental compounds, genetic differences, sex, liver mass, and blood flow. Liver mass decreases by approximately 20% to 30% with age, and hepatic blood flow decreases by approximately 20% to 50%. Compounds undergoing phase 1 metabolism, that is reduction, oxidation, hydroxylation, or demethylation, have a decreased or unchanged clearance, whereas compounds metabolized by phase 2 processes, that is conjugation, acetylation, sulfonation, or glucuronidation, have no change in clearance with age. Drugs with high hepatic extraction ratios, such as the nitrates, barbiturates, lidocaine, and propranolol, may have reduced hepatic metabolism in older adults. Excretion in older adults. Changes in aging kidneys include a decrease in renal mass by 20% to 30%, decrease in renal blood flow, and decrease in tubular secretion. Increases in sclerotic glomeruli and decreases in functioning glomeruli may contribute to a decline in glomerular filtration rate, abbreviated as GFR. After age 30, glomerular filtration rate is estimated to decline 8 milliliters per minute every 10 years, although not all older adults have decreased renal function. The plasma half-life is prolonged for a number of renally excreted drugs in healthy, older adults, and the highest risk drugs are those that depend entirely on the kidney for elimination. Glomerular filtration rate is the most prevalent measurement that is used to evaluate overall renal function and to diagnose kidney disease, using markers that are renally excreted such as creatinine. These markers are measured by collecting urine over a 6 to 24-hour period and drawing blood before or after. Because timed urine and serum collections may not always be possible or accurate in older adults due to inconvenience or incomplete collection in those with incontinence, several equations are used to estimate creatinine clearance. Whereas glomerular filtration rate is used to diagnose and stage kidney disease, equations that estimate creatinine clearance are used to guide practitioners in drug dosing. The Cockcroft-Gault equation is commonly used for most drug dosing. However, controversies exist with regard to using actual or ideal weight, and using correction factors in the calculation. The use of lean body weight in the equation may reflect serum creatinine production more accurately because creatinine is produced in muscle mass, which is decreased in older patients. The Cockcroft-Gault equation depends on serum creatinine concentration and tubular secretion of creatinine, which may result in an overestimation of renal function in obese patients. The next question reads, for renally cleared drugs that require dosage adjustment for AMG, is the Cockcroft-Gault equation an appropriate tool to estimate renal function? According to the Cockcroft and Gault equation, estimated creatinine clearance is equal to opening brackets 140 minus the patient's age closed brackets multiplied by weight in kilograms divided by opening brackets 72 multiplied by serum creatinine closed brackets multiplied by 0.85 in females. AMG is 75 years old, weighs 120 pounds or 54.43 kilograms. And her serum creatinine is 1.9 milligrams per deciliter. Using the Cockcroft-Gault equation, her estimated creatinine clearance is 22 milliliters per minute. The equation was derived from a predominantly male veteran population who had a single measured 24-hour creatinine clearance, and a correction factor of 0.85 is used in female patients. AMG is not underweight or obese, so the Cockcroft-Gault equation is an appropriate tool to estimate creatinine clearance for drug dosing and remains the most common method to determine dosing of renally cleared drugs. Other assessments of renal function, including urine output, should be considered when assessing drug dosage adjustments in older individuals such as AMG, along with close monitoring for adverse drug reactions. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, Kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 573.